I think we are live.
Hello everyone, I'm Devanshi Dalal, Assistant Professor and Clinical Coordinator in Optometry at Department of Paramedical and Health Sciences, Parul University. A very warm welcome to all of you for today's webinar on Understanding Glaucoma as a part of the Glaucoma Awareness. It gives me immense pleasure to introduce to you all our guest speaker, Dr. Reenal Pandit ma'am, my mentor. We welcome you ma'am.
Thank you.
Dr. Reenal Pandit ma'am is consulting glaucoma specialist at Choitram Netralaya in
Can we start, Devanshi? Devanshi, please unmute yourself.
Sure, ma'am.
Yes. Are we good to go?
Sure, ma'am.
Okay.
Yes, ma'am.
Okay. Just give me a moment to start my screen sharing.
Yes, sure.
Is my screen visible?
Yes, ma'am. It's visible.
It is visible, right?
Yes.
Okay. So good afternoon, everyone. At the outset, I would like to thank Parul University and Ms. Devanshi Dalal for inviting me to conduct this webinar and share my expertise to sensitize you all with this very important eye disease, which is a leading cause of preventable blindness worldwide. The aim of today's lecture is to create a very basic understanding regarding this eye disease called glaucoma. So let's begin. Just give me a minute, please. Is the screen visible?
Yes, ma'am.
Okay. Just a moment. My presentation is freezed. Just give me a moment. Just give me 5 more minutes. My screen is freezing on and off.
Okay, ma'am.
Can you see the slides running?
No, ma'am. No, ma'am. No, ma'am. Yes, now. Yes.
Is it running?
Yes, ma'am.
Yes?
Yes, ma'am. Yes.
Okay, okay. I think we are good to start. Am I audible?
Yes, ma'am. You're audible.
Okay, okay, okay. So, extremely sorry for this technical glitch. I think we are good to start. So, we begin with today's lecture. First of all, what is glaucoma? So, glaucoma is a chronic progressive optic neuropathy, which is characterized by the triad of raised intraocular pressure, damaged disc, and visual field effects. Now, how does glaucoma develop? To be able to answer this question, first we need to understand the aqueous humor dynamics. As we all know, aqueous humor is the fluid which is present in the anterior part of the eye, which provides nutrition to the structures in and around and maintains the shape of the eyeball. This aqueous humor is secreted here at the level of ciliary epithelium. Once it is secreted, it enters into the posterior chamber of the eye and travels through the pupil into the anterior chamber of the eye, and finally it gets drained into this trabecular meshwork into the Schlemm's canal. Now, broadly, there are two basic mechanisms by which glaucoma will develop. One is the open angle mechanism and one is the angle closure mechanism. In open angle mechanism, there is an increased resistance at the level of trabecular meshwork. In simple words, the trabecular meshwork is blocked. So what happens is, once the aqueous has reached into the anterior chamber, it fails to drain into the Schlemm's canal through the trabecular meshwork and starts collecting here in the anterior chamber. Now coming on to the angle closure mechanism. Here, the angle of the anterior chamber, which you can see here, is narrow, which means the drainage pathway has become narrow. And so after the aqueous enters here into the anterior chamber, it fails to reach the trabecular meshwork here and starts collecting into the anterior chamber of the eye. Thus, the end result of both the mechanisms is the aqueous humor collecting here in the anterior chamber of the eye. As we all know, eye is a closed chamber, and when there's a fluid retention inside the eye, the pressure will start to rise. Once the pressure starts to rise, it will produce a pressure on the optic nerve behind, and the optic nerve starts getting damaged. Now, what are the types of glaucoma? The glaucoma can be classified based on various factors such as etiology into primary and secondary. It can be classified based on the anterior chamber anatomy into open angle and angle closure, depending upon the age of onset into infantile, juvenile, or adult onset, and based on pathogenesis into congenital and acquired. Coming on to the risk factors of glaucoma, the first and the foremost risk factor is age. As we all know, the most common age group wherein we see glaucoma is between 40 and 60 years. Next is the race and ethnicity. Glaucoma is more common in Africans and Asians. Typically, normal tension glaucoma is very commonly seen in the Southeast Asians. Family history is a very important risk factor. Say any of us have a family member suffering from glaucoma, then that directly puts us to a increased risk of glaucoma. Next is thin cornea. Thin corneas are always slightly susceptible to develop glaucoma in future. Both myopes and hyperopes, especially high myopes and high hyperopes, are susceptible to glaucoma. Any eye that has sustained trauma will always have a lifelong risk of developing glaucoma. Next is the steroid use. Steroid used in any form, be it topical or systemic, can develop glaucoma in the long run in few of the patients whom we tag as steroid responders. Also, patients with certain systemic diseases such as diabetes, peripheral vascular disease, migraine, sleep apnea, all of these are susceptible to glaucoma. Now, what are the symptoms of glaucoma? Mostly, patients with angle closure will develop symptoms like eye pain or pressure, headache, seeing colored halos around white light. When there is an acute rise in the pressure or there is a development of acute angle closure attack, there will be associated nausea, vomiting, headache, and red fiery eyes. Usually, there will not be any visual symptoms in the early part of the disease for open angle glaucoma patients, but as the disease advances, there will be a deterioration in the vision, with the patients leaving with a just tunnel vision in the end stage disease. Remember, glaucoma is the silent thief of sight, and only screening will help pick up the disease in the early stage. Now, how to diagnose glaucoma? First and the foremost is the estimation of the intraocular pressure. As we are repeatedly mentioning, glaucoma is a disease associated with raised intraocular pressure. Now, what is the normal intraocular pressure then? Well, the normal IOP in any human eye ranges between 10 and 21 millimeters of mercury. When the pressure is beyond 21 mm Hg, associated with disc and field changes, we tag that patient as glaucoma. If the pressure is more than 21 millimeters of mercury with a normal disc and normal visual fields, then that group is tagged as ocular hypertension. Always be careful about this entity called normal tension glaucoma, where the IOP is within the physiological range, but in spite of that, the patient has typical glaucomatous damage. As you all know, tonometer is the equipment which is used to measure the IOP. A wide range of tonometers are available at present in the market. Most commonly, you will see one of these in the clinical setup. This is the Schiot's tonometer. Nowadays, it is considered obsolete, but still in India, especially in the rural areas and a small scale setup, you may find a Schiot's tonometer still being used. Non-contact tonometer is most commonly used for screening. This is the Goldman applanation tonometer, and this is the gold standard technique to measure IOP, especially for glaucoma patients. And all glaucoma patients must be subjected to this technique for accurate measurements. Newer tonometers increasingly used these days are the rebound tonometer, that is the eye care, and the tonopen. These all are decently good for screening. Next comes gonioscopy. Gonioscopy helps to understand the mechanism of glaucoma and helps to classify glaucoma into open angle and angle closure. This classification is very important because that will further help to decide the course of management. Now, this is how a normal angle of the anterior chamber will look like upon gonioscopy. I'll try to describe various structures here. This is the Schwalbe's line, and in this case, it is pigmented. Next comes the anterior trabecular meshwork, and behind the anterior trabecular meshwork lies the posterior trabecular meshwork, which is pigmented. After the posterior trabecular meshwork comes the scleral spur, which is the white broad band seen here. And next to the scleral spur is the ciliary body band, and then finally the root of iris. This is how the angle will look like when it is narrow or closed. As you can see, no angle structures which have been described in the previous slide are visible here. Next comes the optic nerve head changes. As we defined earlier, glaucoma is an optic neuropathy. Neuropathy means damage pertaining to the optic nerve head. To understand the glaucomatous damage, first let us understand how a normal optic nerve head looks like. So this is how a normal optic nerve head looks like. This area is called the cup of the optic nerve head, which is slightly yellower in color as compared to this area, which is called the area of neuroretinal rim, which appears pink in healthy eyes. As we can see here, the retinal vessels are centrally arising and there are no vascular signs seen here. Now, this is how a glaucomatous optic disc will appear. The first impression which you get here on seeing this picture is a large cup and an increased vertical cup disc ratio. Most commonly, people associate glaucoma with increased optic nerve head cupping. However, this is a myth because increase in the vertical is not a definitive sign of glaucoma and is just a corroboratory or a soft sign. The definitive signs which indicate glaucomatous damage are notching, optic nerve head hemorrhage, RNFL defects, and pallor of the neuroretinal ring with thinning. All these changes can be seen here in this picture. So let us look at those one by one. Notching means a focal loss of the neuroretinal rim. As we can see here, this is the area of notching where there is an absent neuroretinal rim and the vessel can be seen sharply bending at the margin of the optic nerve head. Optic nerve head or the disc hemorrhage, which is seen here, this area, with an adjacent RNFL defect. RNFL means the retinal nerve fiber layer defect. If you can appreciate here, this triangular wedge-shaped area is looking dark compared to the adjacent areas. Normal retinal nerve fiber layer on the color disc photo will appear bright, as we can see here. If you can appreciate this, these are all the normal retinal nerve fiber layers. And as you can see here, this is an area, a dark area, which corresponds to retinal nerve fiber layer defect, and pallor of the neuroretinal rim. As we can see here, pallor, a temporal pallor is seen here in this glaucoma patient. So all these are the definitive or the hard signs, which means presence of this strongly suggests glaucomatous damage. And there are also certain corroboratory signs or the soft signs, like the increase in the vertical cup disc ratio, barring of vessels. Barring of vessels means the support of the vessels, the underlying support of the neuroretinal rim is lost. That is called barring of vessels. Then asymmetry in the cup disc ratio between the two eyes. If the asymmetry between the two eyes in terms of cup disc ratio is more than 0.2, then it suggests towards a glaucomatous etiology. And nasalization, bayoneting of vessels, which is also again a corroboratory sign and not a definitive sign of glaucomatous damage. So next comes the visual fields. Once the disc starts getting damaged considerably, defects in the visual field will start appearing. In the early stages, we will see defects such as enlargement of the blind spot or the nasal step, which is seen here. This is a patient with moderate glaucoma. Here we see there is a superior notch. Again, to remind, notch is a focal area of loss of neuroretinal rim. So there's a superior notch here, and correspondingly what we see is an inferior field defect here in the visual field. This is the same patient, other eye. Here there is an inferior notch with a adjacent nerve fiber layer defect, and correspondingly what we see here is a superior arcuate scotoma or a superior field defect. This is a patient with advanced disease. As we see, there's a very huge cup with gross thinning of the neuroretinal rim and loss of the nerve fiber layer. Correspondingly, what we see is grossly depressed visual field with only a central small island of vision remaining, which is this. Now, visual fields is to assess the functional damage produced due to glaucoma. To understand the structural damage, OCT is a very useful and most commonly used tool these days. So this is how an OCT report will look like in an eye with healthy optic nerve head. Your OCT will give a color-coded analysis wherein green suggests healthy, yellow suggests borderline, and red will suggest damaged areas. As we see here, this is a patient with moderate disease in the right eye. Again, to describe this clinical disc photo, here there is a inferior neuroretinal rim thinning with a focal loss of neuroretinal rim called notching, with an adjacent neuroretinal nerve fiber layer defect. Whereas the left eye has a normal looking optic nerve head. Corresponding to this inferior neuroretinal rim thinning and notching, what we see on the OCT scan is this red area, which is actually the nerve fiber layer defect. And this yellow and red areas suggestive of RNFL thinning and damage. Whereas in the left eye, what you see is everything is green. That is, everything is healthy here. Let's come to a patient with advanced disease and see how the OCT report will look like. As you see here, the right eye, there is almost near total glaucomatous optic atrophy with a full cup, total loss of neuroretinal rim, and diffuse RNFL thinning. And correspondingly, what we see here is all these red areas you see are the areas of diffuse neuroretinal rim thinning. And this is what you see in the sectoral and clock R RNFL analysis. Everything is in red and yellow. The left eye here is comparatively healthy, and thus you find green zones here. As you all must have noticed, I showed disc photo with every field and OCT report. This is because OCT or field report must always be read in conjunction with the disc changes. That is, the defects must always correspond with the disc damage. When read alone, it carries no value. How to treat glaucoma? The management of glaucoma can be broadly classified into medical therapy, lasers such as laser peripheral iridotomy for angle closure, and SLT, that is selective laser trabeculoplasty for open angle glaucoma, and surgical therapy such as conventional trabeculectomy, the more recent valve surgery, and the latest MIGS, that is minimally invasive glaucoma surgery. So far, we have understood what is glaucoma and how it develops and how to establish the diagnosis. So now let us talk about some practical aspects. Say a glaucoma patient walks into your OPD. What will you do next? First comes history taking. A lot of valuable information which aids in the diagnosis and management can be derived with history taking. Optometrists are the first point of contact for the patient in most of the setups. And as we all know, first chance is the best chance. And here you have a chance to extract as much information as possible from the patient. You must ask the following things. You must ask about ocular redness, discomfort, or pain, symptoms of visual related symptoms such as blurring of vision, halos around colored halos around light, history regarding any glare, difficulty in dark or light adaptation, difficulty following fast moving objects, history of missing any person or vehicle passing by the side of the patient, and history of frequent falls, difficulty in climbing down stairs. For a known case of glaucoma, you must ask the duration of the disease, information regarding the eye drops, which eye drops they are using, how frequently they are using, and in which eye they are instilling the drops. A very important thing to ask is LMA, that is last medication applied. You must ask your patient when did they use the drop last? What was the time and in which eye did they use the drop? Ocular surface allergies are very, very common with all the glaucoma medications, and thus you must ask about any development of burning or stinging sensation. You must ask about history of surgery or laser, and if yes, which type of surgery or laser has been done, which eye, and when it was done. Ask history regarding the refractive surgery. You must ask history about about any family member suffering from glaucoma, and the history of steroid use and ocular trauma. Apart from ocular history, you should also ask about the following things. Apart from ocular history, you also must ask about the following things. That is, history of high BP or low blood pressure, migraine, history of cold hands or feet, history of snoring, history of any respiratory illness or any heart ailment. Once a detailed history has been taken, the workup will start, and this workup must follow the following sequence. First is the refraction. Next comes the slit lamp examination. From optometrist point of view, one thing that you should never miss upon the slit lamp examination is shallow anterior chamber. If you miss a patient with shallow anterior chamber and that patient undergoes inadvertent dilatation, this might precipitate an acute angle closure attack. So never miss shallow AC on slit lamp examination. As soon as you encounter a shallow AC, direct that patient as soon as possible to your consultant and ask your assistant not to put the dilatation drop. Gonioscopy must always follow applanation tonometry, and never gonio should be done before IOP, because that will lead to a false low value of your IOP. Central corneal thickness, optic nerve head evaluation, and then the patient should be subjected to investigations such as disc photo, visual field, and OCT. So from the discussion so far, I hope many of you must be thinking that as an optometrist, how can I make a difference in glaucoma patient care? I think you can make a huge difference because you are the first point of contact for the patient in most of the clinical scenarios. You are going to play a pivotal role in screening. A good clinical evaluation on your end is going to lessen the burden of the doctor to a huge extent. You have a key role to play in conducting the investigations. And your role becomes more important even than the doctor when it comes to dispensing low vision aids for the patients living with advanced glaucoma. It is impossible to run a glaucoma clinic without a skilled optometrist, in my opinion. And thus, I urge you all to work hard and be the difference. Thank you. The second week of March, the second week of March worldwide is celebrated as World Glaucoma Week to create awareness about this potentially blinding disease worldwide. I urge you all to be a part of this campaign and sensitize your friends and family about glaucoma. For learning more about glaucoma, you may also follow my Instagram handle, that is Glaucomacharya. Thank you so much for your patient listening.
Thank you, ma'am, for the wonderful insight, specifically for the role of optometrist. Now, I would suggest the students to type in your questions in the chat box.
I think yes, we are open for panel discussion now and we can take up the questions.
Okay, so first question I could see is from Ayushi. She wants to ask which instrument you would recommend for measurement of IOP during vision screening.
Okay, so for screening purpose, I think a non-contact tonometer would suffice, because an applanation tonometer is a contact procedure and it also takes a slightly longer time and you need patient cooperation. So for screening purpose, non-contact tonometer such as NCT or the rebound tonometer is good. But when it comes to glaucoma patients, like there's a glaucoma patient coming to our OPD, then I recommend only and only Goldman applanation tonometer.
Thank you, ma'am. Another question is, what are the starting symptoms of glaucoma by which we can get an idea of it? Okay, so as a patient, what are the symptoms they should understand? I think that is what they want to ask.
Okay. So, as we have already mentioned, that glaucoma is the silent thief of sight. And unfortunately, in the early stage of the disease, there are not going to be any symptoms in an open angle glaucoma patient. And even in an angle closure patient, maybe only a very vigilant patient will give you history of having slightly, experiencing that pressure on the eye, or seeing those colored halos, or developing headache, especially in towards the evening in the dim environment. So in the early stage, I think 1 or 2 out of 100 patients might give you some symptom that would direct to the disease. Otherwise, it's just a progressive optic neuropathy. That is, there is a slowly gradual progressive loss of vision. Only in the end stage, the patient will come with the symptoms of deterioration of vision. Rest, it is very difficult.
Thank you, ma'am. Next question is from Shivangi. She wants to ask, ma'am, please explain the role of UVM in glaucoma diagnosis.
Okay. So Shivangi, this is a very good question. Glad you came up with this thing. UBM is ultrasound biomicroscopy, and UBM has a very important role to play in the glaucoma diagnosis, especially the secondary glaucomas. Uh, UBM basically can image the anterior segment of the eye in totality. That is, it can image not only the cornea and the angle of the anterior chamber, but it can also go beyond that. That is, it can also image the ciliary body. And at present, UBM is the only anterior segment imaging modality by which the ciliary body can be imaged. And the importance of ciliary body in glaucoma is very high, because that is actually the place from where the aqueous is produced. And the ciliary body anatomy has also a very crucial role to play in the angle closure disease. So for imaging the ciliary body, UBM is the best treatment modality. UBM will help understand the angle of the anterior chamber. So we can image the iris, the root of the iris, how is the anterior chamber angle, how is the iris configuration, whether it is a planar, a convex configuration, or a concave configuration, and the ciliary body. Many of you must be knowing that there is an entity called malignant glaucoma, where there is an anterior rotation of the ciliary body. And this thing can be picked up only and only by UBM. Another important area where UBM has a role to play in glaucoma diagnosis is the diagnosis of all the secondary glaucomas, or glaucomas which develop by the posterior pushing mechanism, that is which produces the anterior rotation of the ciliary body, and also to image the ciliary body tumors.
Thank you, ma'am. There are a few more questions. I would read them out. So another question is, Gaurav wanted to ask if there is a difference in normal IOP range according to the age.
Okay, so this is also a very interesting question. So broadly, we can classify this difference in the range based on the young adults and the adults. So children, say you have a 10-year-old kid, and against that you have a 30-year-old male. So in a 10-year-old kid, the pressure, the upper end of the IOP is usually in the mid-teens. So it is very unusual to see a normal 10-year-old child with eye pressure of 20. Okay. But a 30 or a 40-year-old male with 20 IOP is common to encounter. So definitely in the younger age group, that is, I would say less than 10 years, their upper end of the range is between is in the mid-teens, like less than 15.
I hope that is understood, Gaurav, and we remember that always while doing the vision screening. Another question is why colored halos are seen in glaucoma patients. Okay, why colored halos are seen to the glaucoma patients?
I think this answer question will be better answered by Devanshi.
Okay, so when it comes to your aberrations, the pupillary mechanism and the aberrations, like we saw in the last session again about the aberrations, it gives rise to the colored halos.
Yes, so basically what happens is that whenever there's an acute rise in the IOP, there's fluid collection in the cornea. And that's why whenever we see that there's basically the light beam splits, and we can see those all, light getting divided into the entire spectrum and seeing those rainbow colored halos. But all this is like only textbook described, I feel. I'm yet to, see a patient who comes to me and says that, yes, I do see colored halos around the light. So I think it's more of a textbook thing, and practical scenarios, very rarely you'll see a patient who will tell you about seeing colored halos. So theoretically it stands true, but practically it is not a very sensitive marker.
Okay. Next question is again related to UVM. If there are any contraindications for doing UVM?
Okay, so UBM is basically a contact procedure. It involves placing a cup inside the eye, and then you fill that cup with fluid. So it is it includes a gross contact with the ocular surface. And whenever the ocular surface is breached or there's a corneal disease, as we know, any contact procedure should be avoided. And so the same holds true for UBM. Apart from that, there are no other contraindications.
Ma'am, question from students that if the pressure is greater than 50 mm Hg and you want to go for a dilated examination, is it possible?
Okay,
Or
so
what can be the other
I
option?
think this is a very relevant question because most of the times I get a query from an optometrist, saying that, ma'am, the pressure is very high. Should I dilate or not? So see, basically why we are worried instilling a dilating drop in glaucoma patients is mostly we are concerned for the angle closure of patients with occludable angles. Here, upon dilatation, what will happen is the oppositional this closure will get augmented, and there will be a complete closure of the angle, which might precipitate an attack. So I think to be able to answer this question, first we must know what is the status of the angles, whether the angles are occludable or whether the angles are open. So if the angles are occludable, dilatation is strictly a big no. But if the angles are open, uh, definitely with dilatation, there will be a slight increase in the intraocular pressure. But if dilatation is warranted and it is absolutely necessary, then in open angle patients, it is not contraindicated. You may go ahead with a dilated examination, even if the pressure is 50 or 60. But open angle is the prerequisite. An angle closure, yes, of course, you can dilate once there has been a patent iridotomy that has been established. After that, dilatation is safe, not before that.
I hope that is understood, all of you. Now, next question is how the factors like blood pressure and other diseases induce or affect glaucoma? So, the systemic involvement, I think you want to answer.
Yes, so this is actually a very vast topic, but in a nutshell, yes, the fluctuations in your blood pressure do also affect directly the intraocular pressure. And one important thing in terms of blood pressure is the ocular perfusion pressure. So whenever the blood pressure is low, especially at night time, what happens is the perfusion of the optic nerve head decreases. And in patients with glaucomatous damage, already the optic nerve head has been damaged because of the high pressure. And when the perfusion is hampered, the damage increases. Okay, so blood pressure in this way can affect this disease process. And apart from that, there are a lot of other systemic diseases, as we discussed in the lecture previously, which can affect glaucoma.
Okay, a last question. What are the newest modalities for treatment of glaucoma? So, again, ma'am, you described, but I think they
Yes,
want
yes.
to
So
know it little
lot
more.
of new things are coming up in the management and field. So we have a lot of newer drugs, as you all must be knowing. The conventional anti-glaucoma drugs which are available for management are pilocarpine, timolol, brimonidine, dorzolamide, brinzolamide, and newer agents like the prostaglandin analogs like latanoprost, travoprost. Now, a couple of newer anti-glaucoma agents are there in the market, such as the ROCK inhibitors, the ranetarsudil and the ripasudil. So these two are the new kids on the block, can we say, and which are being widely used in the glaucoma practice these days. So that is in terms of the medical management. Then in the laser SLT, which is not very recent, but recently it has been widely accepted as the treatment modality for open angle glaucoma patients. And from surgical point of view, we have what the recent things which are being done are the MIGS, that is the minimally invasive glaucoma surgery, which include a variety of stents and fancy stuff like the eye stent and the Cahook's dual blade, and a lot of new things are there. So yes, but the mix is still not into the Indian market. All these devices are not available in our market, and the only mix procedure which is at present being done in India in good numbers is the GAT, that is the gonioscopy assisted transluminal trabeculotomy. Only that mix is done here. Otherwise, rest of all the devices are available in the Western market, but yet to be available in the Indian market.
Thank you, ma'am, for the insight. There are a few more questions. We want to ask if would you advise a patient for trabeculectomy and along with other combined surgeries?
Okay, so see, basically, what happens with trabeculectomy is you create an opening in the eye and you create a bypass through which the aqueous will drain into the subconjunctival space. So the role of trabeculectomy in glaucoma is just to bring down the intraocular pressure. Okay, it is not to bring back the lost vision, or it is not to eradicate glaucoma from the eye. So trabeculectomy is advised for most of the patients when the IOP is not getting controlled with maximum tolerated medical therapy. Because what happens with trabeculectomy is it is that filter which you are going to put is not going to function forever. It comes with an expiry date. Most of the trabeculectomy surgeries comes with an expiry date. So if the IOP is staying within the normal range, or which means like you have achieved the target intraocular pressure with say one or only two IOP lowering medications, the patient is able to instill them properly. That is, the compliance of the patient is good. There are no side effects, and the patient can afford using the eye drops, then trabeculectomy may be avoided. But in Indian scenario, what we find is there are so many patients whose compliance is very poor and who cannot afford these costly medications. And for them, yes, even without giving a trial of medicines, you can straight away go for trabeculectomy and bring down the intraocular pressure and save the vision. So it all depends upon a variety of factors, mainly the whether the target IOP is achieved, the affordability.
One more question. It is on which are the available low vision aids for the glaucoma patient you would suggest?
I think again, Devanshi will be able to answer this question better. It is her field of expertise.
So for us as a low vision consultant, the aim for treating the glaucoma patient is to manage for the peripheral field loss. So we have different modalities, including the minus lenses and the prisms, with which we can actually increase the field of vision for the patient. So we have numerous options into it, but the aim is to increase the field of vision, and that is what we do with the prism channels or the minus lenses by the magnification.
I can see a very interesting question popping up here. That is, in case a patient comes with angle closure glaucoma, what we should do in case there are no doctors available. So this is a very yes, very good question. Say a patient comes to you with a very high IOP, and you are suspecting that this is an angle closure patient. Two things to be done. First of all, you check the intraocular pressure. Okay, if the intraocular pressure is within normal range and you see a shallow AC, try and do a gonioscopy and determine what is the status of the angle, whether it is occludable or whether it is completely closed. Okay, so if the intraocular pressure is normal and the angles are occludable, the best help you can do is to avoid dilatation. So you can just mention with big bold letters in the case file that do not dilate, and forward it to the consultant at the earliest. And if a patient comes with high IOP and an occludable angle, or say in a state of acute angle closure attack and there are no doctors available, then from your end, what you can do is you can start pilocarpine and a combination medication, and call the patient like immediately to be seen by the consultant doctor. So this is what you can do.
Few more questions coming in. What are the suggested precautions for the patient with history of glaucoma in the family?
Okay, so if you have any of your family members suffering from glaucoma, you just have to be vigilant and get yourself screened every year. So the screening should preferably start after the age of 40. So what I tell all my patients, who suppose a patient, known patient of known case of glaucoma comes to me, and there is his attendant who is a family member, then I would advise that family member to get himself or herself screened for glaucoma starting from the age of 40 every year. Apart from that, no other precautions need to be taken. You just have to get yourself screened annually. Okay, so we have
What
one
are
more
the
question
effects of
is,
glaucoma on visual field?
okay, so I think this has already been covered that whenever there is a more than 40% loss of the retinal ganglion cells, the visual field defects will start to appear in terms of, in the early stage, what we see is enlargement of blind spot and the nasal step, and gradually they get converted into arcuate scotoma and a double arcuate scotoma. Ultimately, in the end disease, what we have is grossly depressed superior as well as inferior visual fields.
Again, an interesting question. When would you suggest a patient for mannitol and glycerol?
Okay, so both mannitol and glycerol are the systemic medications to bring down the intraocular pressure. Mannitol is an injectable medication. Glycerol is an oral medication. So mannitol and the role of oral anti-glaucoma medications comes next to the topical glaucoma medications. So when the intraocular pressure is not controlled with all the available medical options available, next you have to subject that patient to systemic therapy. So say a patient comes to you with 30-35 pressure and is on all the topical glaucoma medications. So next you would want to control the IOP by giving oral medications first. So in oral medications we have two options. We have acetazolamide, that comes in a tablet form, and glycerol. And usually the role of mannitol is when we want an acute fall in the intraocular pressure. So mostly in my practice, the role of mannitol comes whenever the patient comes with an acute angle closure attack, when he is very uncomfortable and symptomatic with the condition. Mannitol will bring down the eye pressure very swiftly. And next indication of mannitol administration. So for all my patients who undergo trabeculectomy, depending upon the preoperative pressure, I would always want them to get a shot of mannitol before I take up them for surgery. So for glycerol, the contraindication is diabetic patients, and diabetic patients, glycerol cannot be given. Mannitol, definitely if the blood pressure is high, we must defer. We must first control the blood pressure and then subject the patient to this IV mannitol. And next is we must know the cardiac status of the patient grossly. So if the patient has a decompensated cardiac status, then mannitol should be avoided.
Ma'am, I'm reading out the questions through Facebook. The question is from Urvashi ma'am. She wants to ask if there is increase or decrease in the refractive error component due to glaucoma.
Mostly it is a fluctuating thing. So with the increase in the eye pressure, what we usually notice is fluctuation more than a directly proportional increase or decrease. And whenever there is an angle closure glaucoma patient with a posterior pushing mechanism, you will observe a hyperopic shift in those patients.
So connecting to that question, any comments on prevalence of glaucoma in specific refractive error?
Yeah, so your myopes will tend to develop open angle glaucomas, pigment dispersion glaucomas, and hyperopes tend to develop angle closure glaucomas because hyperopes have a small eye. So that predisposes them to a crowded, anterior chamber angle and occludable angle, thus subjective, making them more susceptible to angle closure glaucoma. And
Thank you,
myopes,
ma'am.
one more thing about
Again,
myopic eyes are also more sensitive to steroids, and steroid responders usually will be myopes. Myopes will respond to steroids more compared to hyperopes.
thank you. Sorry to interrupt. Again, the continuation question for the mannitol thing. They wanted to ask if the patient is having hypertension, can we suggest mannitol or not? And when do you suggest mannitol or glycerol? That is what.
Yes, exactly. So I think this has been answered. Hypertensive patients, yes, we can give mannitol, but the blood pressure should be within the normal range with medicine. So if the blood pressure is very high, very much above the physiological range, then we must have to control that first to be able to inject mannitol. We cannot inject mannitol with patient with very high blood pressure. So that is one systemic contraindication, relative contraindication, not an absolute one.
Thank you, ma'am, for your patient answering. I hope all the questions are answered. And if any more questions, you can connect to ma'am through the Instagram handle. So, because we are running out of time,
Yes.
I would like to thank you,
I'm
ma'am.
glad all the students, they had so many questions in their minds, and they came up with this very interesting questions.
This was the most awaited session till date. So, thank you for accepting the invitation and making it such an
Thank you
interactive
so
session.
much. It was absolutely an honor and pleasure to be here.
Thank you, students, for joining in and making it an interactive session. And thank you to the webinar team to make it possible for all the optometrists, ophthalmologists, academicians, and the optometry students across India to join in and understand the importance of glaucoma. Thank you all. Have a great day. Bye-bye.
Thank you. Thank you.